and welcome to my podcast, Dine with Doc. My name is Dr. Sanjay Arora, where I bring you interesting conversations with medical experts to unravel some of the mysteries in healthcare. Today, I have the privilege of inviting a very dear friend, Dr. Pradeep Rao, as we fondly call him PP. Welcome, PP. Thank you for giving us your time today.
Thank you for having me on your podcast, Sanjay.
So, Dr. Pradeep Rao is the director and senior consultant at Gleneagles, Reliance HN, and Jupiter, leading hospitals in Mumbai. Is recognized as one of the top urologists in Mumbai and a place in the best doctors list for 5 consecutive years. He leads a team of urologists and he spearheads groundbreaking advancements in uro-oncology, is the pioneer of single port surgery amongst others, and he has many world firsts. Welcome, and let's start by having this dine with doc with a healthy coconut water.
Thank you, Sanjay.
You want to tell us some of the pioneering work that you've done? I know we spoke about single port surgery, but give us a quick overview of some of the pioneering work that you've done over the last few years.
I was fortunate to be doing my urological residency at a time when there were a lot of advances in laser technology, in minimally invasive surgery. I was one of the first people in India to start doing laparoscopy in urology.
Right.
And as a natural extension of that, when an opportunity came to try a new device which could do completely scarless surgery, we left it. Then me and my brother is a general surgeon and I'm a urologist. We did a lot of surgeries which were world first at that time in 2007.
Okay.
And this procedure went pretty much viral all over the world and created a whole new specialty of single port surgery, which was completely scarless because we could do the entire surgery only through the belly button.
Right.
So
Okay.
you would end up with no scar
No
at all
scar.
because you're using an existing scar. Now, of course, with the advent of robotics, robots have taken over many of those surgeries. In fact, Intuitive Surgical, which made the robot, was forced to make a single port robot just to compete with single port surgeons.
Wow. Okay.
So now you have a single port robot as well.
Okay. So I know, I was reading about this that you lead a team that specializes in robotic kidney transplants and managing all urological cancers, as you just spoke about minimal
Yeah.
access surgery and conducting laparoscopic procedures for organ donors. You want to maybe shed some light on this?
Of course, laparoscopic donor nephrectomy. That for me, it's always been a thing that in kidney transplants in India, unlike the rest of the world, the majority of our transplants in India are live donor transplants,
Right.
where a relative gives the kidney. Usually, it's a spouse or a sibling or a child.
Right.
And none of these people who are giving kidneys to save somebody's life, they're not patients. They're
Normally,
normal people.
Right.
And they need to have minimize their time away from work, minimize their discomfort because in the end they're
Post-operative
not
risk
patients.
should be
Exactly.
the least.
So these people really deserve laparoscopy. Unfortunately, this is one of the fields where Mumbai has been very backward compared to the rest of the country.
Okay.
Even today, we are the only team doing completely laparoscopic donor nephrectomy. I've not done an open donor nephrectomy for 25 years now. I was trained in open donor
Wow.
nephrectomy, but I never did one after that. And we have done, I think, close to 900 consecutive transplants with only laparoscopic donors.
This is a very important aspect that you just spoke about, that
Absolutely.
people talk about the patient, but not about the donor,
No,
who's actually not even a medical patient.
Not even a patient, yeah. And in transplant surgery, one thing is that a true dictum is that the donor is much more important to us than the recipient. Any
That's
complication in a
interesting.
donor is a major red flag. Kidney donors, we don't explain death as a complication
Correct,
because it's
correct.
totally unacceptable to have a donor
Absolutely.
die.
Right.
It's not acceptable at all. But even other complications, any major complication is not to be taken lightly.
Absolutely.
And with laparoscopy, we can reduce that. The donor is back home in 2 days, and in a week, they're back to normal work. And that's a big deal. Because the open donor nephrectomy, removal of the kidney with an open incision, is 1.5 feet incision, 18 inches.
Wow.
And removal of one rib. So you're creating a fracture and removing one rib, the 11th
Right.
rib, to get access to the kidney. In a laparoscopic donor nephrectomy, you have 3 incisions of 5 millimeters and one of 8 centimeters to take out the kidney,
Right.
which is in the bikini hairline. So
Right.
it's not seen later. This is a very big deal, and it's an important thing.
And does this in any way impact the people who want to become donors, saying that,
Hugely.
Yeah, I mean, that,
Hugely. Introduction of laparoscopic donor nephrectomy in 1997 in the United States. I trained at Cleveland Clinic around that time. The year before the laparoscopic donor nephrectomy were introduced, Cleveland had done something like 5 open donors.
Okay.
The next year it was 50,
Okay.
and now they do about 80 to 100 every year.
Wow.
And most hospitals in the US will report similar numbers.
Right.
And once laparoscopy started, patients started coming forward. In India, it's not the same because here to prevent dialysis and to save people's lives, people are still donating with open surgery.
Sure.
But obviously, it's a lot easier to convince them to donate their kidney if they're doing it laparoscopically.
But this is great. And no, thanks for sharing this, BP. I think this is something even for me that I was not aware that
Right.
how you are focusing so much more on the donor rather than the patient only.
So I was always interested in transplants mainly for laparoscopic donors.
Right.
But after seeing the passion of my nephrology colleagues, especially Dr. Bharat Shah, in treating patients, because believe me, chronic kidney disease and end-stage renal disease is a debilitating disease, not just for the patient, but for the whole family in India. It drains you of all your resources, and
Right.
these patients genuinely deserve our help. So I have become passionate about kidney transplant as well. I don't do open kidney recipients because I've never been interested in open surgery since forever.
Right.
But now we are doing robotic recipients.
Okay.
And I believe that in 4 or 5 years, there'll be no more open surgery for kidney recipients. We're doing regularly robotic kidney transplants, which have excellent outcomes and significant benefits over the open operation.
And robotic is performed at all of the 3 places where you operate?
Yes. Well,
At-
my team only does it.
Okay.
As of today, we are the only team in the state of Maharashtra doing robotic transplants.
Okay.
But I'm sure other teams will pick it up in future.
Right. Right. So just to make it easy for our audience to understand the difference between non-robotic and robotic, maybe if you could just give some
So
clear.
just like a open donor nephrectomy where they take an 18-inch incision,
So a nephrectomy, you mean removal of
the kidney for the transplant. When you put the kidney back in, the regular open transplant incision is about a foot to a foot and a half.
Right.
And they incise the muscles, all 3 layers of the abdominal muscle, and make space to put the kidney in.
Right.
Now, this operation has 2 major disadvantages, although it's a standardized surgery which has stood the test of time. You're taking a big incision, cutting muscles in patients who are going to be on immunosuppression to help the kidney to survive.
Right.
So their healing is low because you're giving them steroids for immunosuppression, so they don't heal well. And you're cutting muscles and you expect those muscles to heal. In a routine surgery, we would remove stitches in 5 days to 6 days.
Right.
In a transplant, you remove after 2 weeks.
Okay.
Because you give it more time to heal.
Right.
In a robotic recipient, there's no incision over the kidney at all. So the healing process is easier. A lot of our kidney recipients are diabetics who also don't heal well.
Right.
In addition, you're giving them steroids, so they heal even worse. Once you do a kidney transplant, there is urine immediately out there. Urine and fat and muscle don't mix well. Yeah. So these people get collections. Once they get a small infection in the wound, you have to bring down the immunosuppression. That increases the chances of their graft dysfunction, the kidney not doing well. So all these problems go away when you do a robotic transplant.
So robotic is basically having 2 surgeons, doing it parallelly with you.
We need 1 surgeon at the bedside.
Right.
And 1 surgeon on the console who's actually operating.
Right.
If I'm on the console, I have a colleague who's on the bedside who's helping me out, putting the kidney in, giving me the sutures to help me sew and all. As of today, the only disadvantage that I see to a robotic transplant over open is the cost.
Sure.
Because the usage of the robot costs something.
Correct.
As long as that we can bring that cost down, I don't see any open transplants happening.
Correct. Interesting. And would majority of the reasons for kidney transplant be diabetes? Chronic renal failure due to diabetes?
Diabetes is the commonest cause of kidney failure in India with transplantation. And fast coming up as the second commonest cause is, unfortunately, Ayurvedic medicine.
Really?
Yeah. Because a lot of these Ayurvedic medicines,
lead poisoning.
They have heavy metals mixed in, and they're not regulated. It's not a regulated industry. So that's one of the problems we are seeing of late. Yeah.
We're talking about the prostate gland today. What's the significance of the prostate gland, and what would be, in your experience, the telltale signs for a male patient to start being aware about his prostate gland, and when they should come to you or to a neurosurgeon? Prostate is an organ which is present in all men. Right. And as part of the process of aging, the prostate begins to grow. Right. So once you're beyond the age of 40, your prostate has to grow. Okay. The only people in whom a prostate doesn't grow beyond the age of 40 are those who are castrated before that age. Okay. So castrati do not have an increase in size of the prostate. Everybody. That's because The testosterone stimulation.
Yeah. So it's a testosterone-driven gland, and it doesn't increase in size once you remove the testes.
Right.
All other people will have the prostate grow from the age of 40, and that's part of the normal process of aging.
Right.
An enlarged prostate doesn't mean you need treatment. An enlarged prostate just means that you're a normally functioning male. Now, when do you need treatment? Of, say, 100 men growing beyond the age of 40, I would say 20% of them by the age of 50 would have some symptoms while passing urine.
As early as 50?
Yeah,
okay.
Because you already given 10 years for the prostate to go.
Right.
They would have some symptoms.
Right.
It doesn't mean they need treatment yet, but they may feel they have to go to urine more often.
Right.
They may have to get up a couple of times at night.
Sure.
These are not alarming things. They're just signs that you're aging and you're growing up.
Right.
By the age of 60, 20% would require some sort of treatment or the other.
Okay.
Usually medical.
Okay.
Of late, our drugs have become so good. And in the last 30 years since I joined surgical training to now, in those days, we didn't have any medicines. So most patients would end up with some sort of surgery or the other. But now the medicines are so good that most patients don't require surgery. I would say 80% of those who have symptoms can be treated medically.
80%?
80%.
So I'll give you an example. My father had his first prostate surgery in his early 50s. And subsequent to that, he had 2 more prostate surgeries for the prostate gland. So in his 30-year span after 50, he had 3 prostate surgeries. So you want to just maybe explain that the prostate gland can regrow even after surgery?
If your father, we are the same age. So your father would have been in his 50s in the 80s.
Right.
There were no drugs available for the prostate at that time.
Right.
So most men would have ended up with surgery,
right,
with symptoms, which they didn't really need. Because today we know that patients with symptoms of prostate have 2 types of symptoms: irritative voiding symptoms and obstructive voiding. The difference is irritative voiding means you go often to pass urine,
right,
you get up a few times at night.
Right.
And obstructive voiding means it doesn't pass completely. You have urine left behind. You go more often because you're not passing all the urine.
Right.
The obstructive voiding guys, they may be helped by surgery if the medicine don't.
Right.
The irritating voiding guys will not be helped by surgery no matter what you do. It's only medical treatment that they need. But in the past, we didn't have this because there were no drugs. But now there are so many drugs, and they're getting better every year.
Right.
That most people are treated with medicines alone. We have a few concrete indications that surgery is still ruled.
Right.
But otherwise, most patients will get medical treatment. So your dad probably wouldn't have had the surgery in the 50s.
Right.
And he may have required 1 surgery later, or may not be with the medicines that we have today. But we don't know.
But because he had 3 surgical interventions, prostate gland, it can regrow, after some time.
So the prostate is a complex organ. It has 4 or 5 different zones.
Right.
It's just the zone which is on the side of the urethra, which is your urinary tube. That when it enlarges, it causes a block and needs surgery.
Right.
Or medical treatment.
Correct.
Now, that particular gland, so that when we do a surgery for benign prostate, which is all these urinary symptoms, we remove the adenomatous part of the gland, which is the transitional zone, which is along the urethra.
Right.
This can regrow.
Okay.
Because you're not removing the whole prostate.
Right.
But usually with modern day surgery, with bipolar TV or the laser, it's unlikely for it to regrow if the surgery is done well and properly. But I would never say never in medicine or the human body. 20 years, maybe yes, but less likely. And my patients ask me all the time, that am I going to need surgery for this?
Okay.
I say it's very unlikely.
Unlikely.
Yeah.
Okay. That's good to know. And tell me, some people don't get symptoms. As you said, 20% will get symptoms maybe in their 50s. But many people I've seen don't get symptoms even till their 70s and 80s. So why is the reason for this kind of a variability?
It's impossible to tell. I have seen patients with 250 gram prostate, which is huge. It's like a tennis ball.
Right.
And
normal size is about
normal size 35, 40 grams.
Right.
250 grams, no symptoms whatsoever. They're absolutely fine.
Right.
And they'll live their entire life without ever requiring treatment.
Okay. And because it's not obstructing the passage of urine.
Yeah, it doesn't. And I have seen patients with 10 gram prostate with severe symptoms requiring surgery. So size of prostate is not a reason for surgery. Almost never.
Okay. It's the
symptoms.
Okay.
Only 2 things impact our decision for surgery in BPH, that is benign prostatic hyperplasia.
Right.
Symptoms and the flow. The only thing that surgery does is improves the flow.
Right.
If you have a good flow, but still symptoms, probably all you need is medical treatment.
Okay.
But if you have a poor flow and your symptoms, surgery will definitely.
But this is a great takeaway that size alone is not a
No.
determinant for surgery. It's
And
the
my
symptoms.
radiology colleagues are trained to write the prostate is enlarged.
Right.
And we get a lot of patients saying, Doc, I have a problem. You don't have a problem. Your prostate has to be enlarged.
It has to be enlarged. It means you're normal, actually.
Exactly.
Right.
And they say enlarged whether 30 grams or 40 grams or 50 grams, because they're trained to write that in their reports. That once the guy is above 40, you write the prostate is enlarged.
Right.
It's like a format.
Correct. So maybe I'm concerned, that my father had prostate, enlargement when he was quite young, and I'm 58. Should I also be worried? Is there a genetic influence on prostate enlargement?
So prostate cancer has a strong genetic association. It runs in families.
Okay.
But BPH, like I said, it's a process of aging.
Right.
We do see that if a father has had a large prostate, the son is likely to have a large prostate.
Right.
But it doesn't mean that he needs treatment, because like I explained to you, unless you have symptoms, you don't really require treatment. Size of the prostate is not important.
Right. Okay. Prostate cancer has a definite family linkage.
Very strong family association.
Right.
So once somebody gets prostate cancer, we test his brothers, we test his sons, and his brother's sons, because that's where it runs.
Okay. And a genetic testing obviously has evolved significantly for you to be able to pick up markers.
Yes, it has, but not so much being done in India these days.
Okay.
And where the genetic testing really helps is to know your risk of developing metastatic prostate cancer in the future.
Okay.
But again, prostate cancer, this is a different field story altogether. Now there are so many effective treatments available.
Right.
And I don't see how it matters.
Yeah, we'll come back to that, but let's take a break and maybe grab a fruit.